Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement of value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. On this program, we explore stories from the field about how real organizations are dealing with this change. As always, you can follow the show on Twitter at #VoicesInVBC and follow SPH on Twitter at SPH Analytics. On the program today, I'm talking with Dr. Sarah Martin, Vice President of Health Solutions for mySidewalk. Welcome to the show. It's great to have you.
Thank you for having me.
Super interested to hear about what mySidewalk is doing. But before we dive into that, why don't you tell us a little bit about yourself and kind of what brought you to this point in your career?
Happy to. It's a lot of twists and turns, so I'll just keep it super brief. So whenever I kind of get asked this question, I always think back and I think of all the plans I had that I didn't do. And I think that's, kind of how I ended up where I am today. Is so different than where I thought I'd be. So I'm just a working class kid from Bakersfield, California, which is smack dab in the middle of the state of California. It is a very red county politically, and it is one of the sickest places in the country. So if the Central Valley of California were its own state, it would be the second sickest state in the country. A state with a lot of health and prosperity, and the fifth largest economy in the world, So I kind of came up in that space. Thought I wanted to be an actor, thought I wanted to be a lawyer, thought I wanted to be a journalist, and then met some journalists who were like, you don't want to be a journalist, when I was working on some campaigns, and I ended up at policy school. So just by the grace of God, ended up at UC Berkeley, which is the Goldman School of Public Policy, and is number one, I believe, and U.S. News and World Report would agree, the number one school for policy in the country. While I was there, I got really involved in public health, which is, again, not part of the plan. And I ended up getting a dual degree in epidemiology, which, as everybody now knows, because there's a lot of armchair epidemiologists in the world right now, is a study of disease. So I had this MPP and then an MPH, and I was fighting to get a dual degree designation for epidemiology and policy. And nobody could see kind of like why you would want to do that. So I had to argue that was a natural marriage, right? Nobody would argue that now. So it was really just such a heyday to be at Berkeley. Epigenetics was really big. The ACA was on the horizon. There was just a really good time to be studying that. I stayed for a PhD in policy and economics, and then ended up in an academic role in Kansas City, which is how I ended up in the middle of the country. It wasn't, anywhere I'd ever been before I interviewed for the job. Spent some time on the tenure track and just got very depressed and isolated. And my research was very, very applied. And so the idea that we were fighting to get in these journals and it didn't appeal to me. And I needed a change. So went back to policy, my first love, and ended up at the city for quite a while in leadership at the city. And now I'm at mySidewalk, a tech startup. So you can tell that there was the best laid plans of mice and men. That's always my favorite, my favorite quote.
Those dots wouldn't draw a straight line if you connected them, right?
No. And actually, a year before I ended up at mySidewalk, I had the opportunity to make a keynote address at our largest health department convening. So it's the National Association for Health Departments, and it was just an awesome opportunity. There's thousands of people in the crowd, and I made fun of startup tech bros, I call them. I made fun of men who wear backpacks and to work, and I was just making a joke about how we have to be careful about startups who claim to have the next best thing for public health. And then fast forward a year later, I was a vendor at the same convention, in my startup booth, and so many people came over and were just absolutely making fun of me the whole time. So
I could only imagine. That's a great story.
Yeah.
You mentioned something, applied research. Tell us what applied research is and what it is and why it's different.
Yeah, and I will say that with a caveat of I'm not going to put all the blame on academia, right? So, there is a lot of kind of posturing over purpose in academia of the game is rigged. I mean, it's like if you're like a person of color, you're a woman, you're someone who didn't kind of come up in this world, to learn how to navigate the tenure system and to learn how to navigate, how to get accolades is all about getting in the right journals, getting the right research grant funding, and it's such a rat race that the policy implications section of any economics paper, say, is like half a paragraph. I mean, and it's kind of an afterthought to throw away, where I was thinking like, saying I'm most virtuous. I think I'm just impatient. So yes, does like super high level, awesome micro econ research make its way into, the president's Oval Office when he's thinking
Right.
about policy? Yes, but that's one of thousands and thousands of econ papers, right? And so I'm
Right.
so impatient that I'm like, I need to see the results of this research implemented immediately. So, which is why local government was so appealing to me, because I thought I could take this research I did at the university in town, walk down the street to City Hall and say, look, an earned income tax credit at the local level will save this many lives. Like I could actually like do that locally, which just feels good, right? And it doesn't mean
Right.
it's going to be trusted though. So on the other side, instead of just blaming academia for being ivory tower, right? But I came out of that ivory tower. We have the government folks who, on the other hand, don't have the bench to like in their organizations to do the research themselves, right? And they want to partner with academia, but they also don't have the money because academia's got, a 50 to 60% overhead to the university. And
Right.
like, how can you afford six figures as a local government to do this work
Right.
with universities? And so on both sides, there's this idea that if we want research to inform policy, which is what applied research would be, no one's doing it, right? Like on either side, right? The policy folks not either producing or listening to research, and the researchers not speaking the language of policy and putting it in terms that people can understand.
Right. And that leads nicely into kind of, you spoke about the local government. So you were the deputy director of Kansas City, Missouri Health Department. When you move from academia into that world, what are some of the things that you learned when you made that shift and you were kind of, let's say, on the ground?
Yeah. I mean, trial by fire, honestly. It was a new deputy position because it was really focused on policy. So health departments, like, you can see now, right? Like so much of our public policy can come from public health, right? Whether it's a mask mandate or it's a seatbelt law, policy saves more lives than any sort of clinical treatment, right, that we would be giving in a doctor's office. And so, I came into it really, I think, a little bit naive, right, about how our applied research, our data informed angle would be adapted into city policymaking. And I love politics too. Like it is not like I'm thinking, okay, this is a mix, right, of like politics and marketing and policy and research. I think that a couple hard lessons is one, nobody cares about most of the things that you care about, right? It's very humbling. We had this amazing community health improvement plan. It's something that a health department has to do to stay accredited, but it is the right thing to do. It's supposed to belong to the community. It's kind of like, here are the issues that matter. Here's what we're going to do about it as a community. Keep us accountable. So we did our health improvement plan all around social and economic conditions. We won awards for it nationally. We brought in a designer. We did everything right. And we looked at the analytics of how many people read it. We had 37 downloads in a year. And like, keep in mind, like Kansas City's not small. It's 500,000 people. We had 240
That's
FTEs in the health
crazy.
department. Our metro's 2.5 million, and it was award winning. So you would think you'd have some sort of like national spotlight on this chip, which had never, the acronym, which had never been done in this way before. So that was a hard pill to swallow, right? You spend a lot of time on these things and maybe nobody cares. And that extends even, I think the hardest lesson was it extends even to, your elected officials. And so it's very freeing now, not being in city service. I can talk about things like this a little more openly, but my job was to get council to pass laws. Like that was my job, right? A
Right.
lobbyist, say
Right.
like,
Yep.
inside government lobbyist. And I remember we were working on school discipline, which is, you wouldn't normally think is a traditional health function, but we saw the school to
Right.
prison pipeline starting early. So I was like, we got to keep this story simple. I'm not going to go into like regression analysis and machine learning and all the like pie charts, like 2 pie charts. And so I put up this slide in front of council and it's aired live on channel 2. And it's like channel 2 is like what nerds watch during the day. It's like our C-SPAN locally. Uh, so 2 pie charts. One pie chart was the racial breakdown of all preschoolers in Kansas City. And it mirrors the population, 30% Black, 20% Hispanic of any race, 40% white. Like, it was pretty. Then I would show
Right.
a pie chart right next to it, of the racial breakdown of all suspended preschoolers. So when I say suspended, I mean suspended from school for greater than 10 days, which I don't know what preschoolers are doing to get suspended. But
I was going to say that blows my mind.
right,
Yeah, that that's
right.
even possible.
And absolutely. And that pie chart was 90% Black, and almost all of them were boys. So this was like, I was thinking, there is no way anyone can look at this and think we don't have a problem, right?
Right.
And I had a councilwoman look at it. She's like, well, that's a little unfair because we don't know the population of preschoolers. I was like, the pie chart on the left. And now, granted, I'm cameras on my face. There's 10 people at home watching
Oh, yeah,
this,
good
probably my
point.
parents,
Good point.
I'm trying to, and my employees would text me, watch your face, because I will be making a face that shows how angry I am or frustrated. So I'm like, okay, respectfully, that
Mhm.
that pie chart is the population. So we're seeing it, and then of course it's not race, it's income, is what I hear, and how do you argue with implicit biases? How do you argue and undo stereotypes? How do you with a pie
Right.
chart, right? It's
Right.
necessary, but it's not sufficient. And sometimes you're just never gonna break through. And I think that was
Right.
that, and you don't need all of them. That was some of the best advice I ever received from our last mayor. He said, Sarah, you don't need all of them. You just need 6 of them. And I was like, okay,
Yeah,
well,
good
stop trying
point.
to win everybody, and that was like
Yeah.
very good. And I've kept with me even now.
And fighting that implicit bias obviously it bleeds into the healthcare world across the board, right? There's been a lot of discussion about it. And I think it's one of the challenges that everybody faces when we're trying to figure out how best to improve the healthcare system is dealing with those. And it's interesting that even at the, call it non-healthcare education world, it just is, it's human nature. Not great human nature, but it is good human nature. And it's something that we need to work around or over or through to get to where we need to be. And one of the ways that you were talking about doing that when we were preparing for the podcast was the importance of humanizing the data with stories to really engage the stakeholders consuming the data. Tell our audience about that and the concept and also the approaches that you've taken.
Yeah, absolutely. So part of, getting people to pass laws or getting them to do something differently than they normally would is convincing them that there's a problem, right? That's like number one. And so I can come in as a researcher and say a 1% increase in the likelihood of mold in a house leads to a 5% increase in asthma among children. 30% of their asthma is caused by indoor air irritants. Like I got all that in my head, right? We were trying to pass a law for rental inspections for housing quality. And so we learned, guess what? Nobody cares. Like nobody can see a number in their head. Plus, do you know how many times I literally have to explain the difference between a percentage point and a percent difference? Like I draw that out to people once a day. So even you've already lost folks, and that's no fault of your own, right? It's just like you're dry, you're uninteresting. So what we did was actually like, okay, what drives people? Like what gets people's attention? And we realized it was their kids not being able to go to school. And we see that now, but like this was, 2018, 2019, they were really driven by the idea that kids, and we came up with a marketing statement around it. Kids can't learn if they can't breathe. Talk about like just straightforward, not talking around the issue, not, using very active language. And then what we did is this is when I was at the health department working with mySidewalk, and we worked with UCLA as well, friends there, to say, let's turn that into people instead of data points. And so let's estimate the number of more school days you would get in every zip code in the city if this law were to pass and be 30% successful. Like we have parameters and assumptions,
Right.
but go to the white paper for all that. Go to the
Right.
journal for my model, because I'll show you what that looks like. UCLA's got top-notch researchers. Like they've got that on lock. I'm just going to make sure that the public can remember my zip code would have 17,000 more days of school for our kids. That's what advocates needed to go lobby to get this law passed, because we couldn't lobby directly because we're a public agency.
Right.
So what we needed to do was humanize that data and make it really salient and really meaningful. We often talk about life expectancy differences. You've heard it, I'm sure.
Yep.
It's a big deal in healthcare and public health. And we'll say, oh, 93305 lives 10 years less than 93301. And instead of that, we turn it into, if you drive 6 minutes down 63rd Street, you lose 15 years. Like, same thing, different approach. One puts you in the car. One puts you driving down a street everybody knows. One has your kids staying home from school and you're panicked because you don't have childcare and you can't go to work. Like,
Right.
those are the feelings we need to feel when we hear good stats, right? People already don't trust your statistics. This is a time I've never seen so
Yes.
much distrust of scientists and researchers. So we have to sell it, but we have to be careful that we're like keeping in our pocket the credibility and integrity, and that we are using research, really good research methods. We
Right.
are following the rules, right? We're not lying with data, but we have to tell a better story.
And this was part of what I found so fascinating, because everything's data, especially in value-based care and population health, right? It's data and analytics and everything else. But the reality of it needs to take the next step forward, right? Just data, just numbers doesn't drive human behavior. And at the end of the day, it's all about changing and driving human behavior. And the term marketing so often can be viewed as a negative by a lot of people, right? Oh, you're trying to sell me something I don't need. But in reality, it's so needed to drive the change we need, right? It is, don't take the negativity out of the word marketing. You got to really think about, how do I drive changes to people based on data, knowing that data and numbers alone won't do it all the time, or often any of the time. That was one of the things I really loved about the conversation, and hopefully the readers can take away from that in their own roles. So now you're at mySidewalk. You're leveraging all the experience that you've had getting to this point. Tell us about what you are doing with mySidewalk, what mySidewalk's doing.
Yeah. So, I mean, you kind of mentioned the marketing piece of it, and part of it is creating replicable, curated stories for people that they can use to advocate for the things they want, that look pretty, but probably the most important thing, like mySidewalk is a software company, right? We're not a consulting firm, we're a tech startup, and our business is democratizing data access. So data is power, it's knowledge, it's information. So people look at data, they're like, numbers. No, data is insights, and it they're waiting to be had. It won't happen by itself. You obviously need to get in there and analyze it. And this is going to sound like crazy, but I believe if the government wanted us to have better information more easily, they could do it, because they have enough resources to make data flow freely, be useful, be actionable, be ADA accessible, be mobile optimized. There's all these things that mySidewalk does is really just filling gaps in what should be a public good or a public service. So we take data from 50, oh gosh, like now it's like 75 different public sources. We take it, we clean it, we cross-tabulate it, which means that we often take like two different data sets and put them together. So if you wanted something like income by race, by zip code, that's going to be living in this library. So we've amassed this very beautiful, what we kind of refer to now as a social determinants of health library, right? And that phrase is often overused and under investigated in the way we talk about it. But that's an easy phrase to use, especially because we work now more in healthcare than we ever have before. So we're taking that data, we're breaking down barriers to that data, and then we've created a publishing platform to tell the stories, to spin up stories, to share them on the web, unlimited number of stories, data updates automatically. We're taking away all those pain points, right? This isn't anything, as we talked about before, like I thought I'd ever be doing. But there was something so special about the opportunity to encode the expertise of public health, community organizing, journalism, politics, and put it in a space where one day healthcare institutions who are seeking, as we move like value-based care, like you talk about cheap, put a roof over someone's head, take out the mold, you're good to go, right? You'll never see that person except for your checkups, you know?
That's right.
But it's scary. It's a scary world for healthcare to have to wade into these big social and economic structural issues. And then you add race and class and you know, all of the kind of marginalized populations, and it can feel really disorienting for healthcare leaders to try to navigate that. And that's where mySidewalk has really become, in a very short amount of time, a bridge between public health and healthcare. Our first health solution only launched mid 2018, and it was mine when I was a customer. So between mid 2018 to mid 2020, we've had like I can't even quantify the growth. I mean, we went from 0 to 50 to 100 cities to very, very quickly. And now having large healthcare partners is just a dream, because that just means it's getting in more hands. At the time I took the mySidewalk offer, I was ready to take an offer to be a health director. And that was supposed to be the next rung on the ladder, right? Go from deputy. It was a health director for the 4th largest health department in the country, closer to home, closer to everything I wanted on paper. But I knew there was something special here, especially when it comes to that. The heart is that data. And it's unfair and it's unjust that we make it so hard as a country for anyone to get access to their data. That's me in that data, you know, that's public. And the word public, you know, available does not mean accessible or useful. So we're kind of blowing that up. Yeah.
Yep. And anybody that's worked with CMS knows that is very true. All the data's there in some data set somewhere, but unless you have some data analysts that are good at doing it and then spend a lot of time getting it usable, great, it's publicly available, but it's not usable. It's not accessible, especially not to the general person. And it's really
interesting, right? Because I mean, to your point, sorry to interrupt, but like you said something really powerful, like even if you had an analyst, and we work in many rural areas, so that's like a shout out to Navajo County, Arizona, right? Who they have 1.5 FTEs. Their director like uses mySidewalk to make his Christmas card to the community. Like rural counties who have never before ever made a map of life expectancy. That's bananas to me, right? And then we expect them to be storytellers too. So even if you had an epidemiologist, we're like, now I need you to be a social marketer, a good communicator, really good at writing. We're asking so much of people, even in these billions and billions of dollar revenue healthcare organizations that we talk to regularly. Just because you have a data scientist does not mean that anyone's going to pay attention. And so that's where we can try to like at least give some tools to say like, have you thought about starting with a really powerful statement? Let's go through a workshop on how to, you know, and just really trying to productize that process of creating good stories is a big challenge.
Absolutely. I think it makes a lot of sense. In calling out the, you know, rural areas is a great call out, right? Because there are never any resources in those areas to do any of this level of stuff, in the power of the tool, bringing that together. So we've had others on the podcast about social determinants of health, and of course, with COVID going on and everything else, it's gotten more and more spotlight on it. And it seems like it's finally starting to really play into where we're headed in a healthcare system. How do you think in the next handful of years, 5 years, it unfolds from a value-based care perspective? Do you think it's really going to get infused, or do you think that's more of a 10-year horizon? Curious. I asked this question of of a lot of people, and it's a bit of a crystal ball, but curious.
Yeah, who's trying to predict anything these days? That's silly.
That's right.
Yeah. Here's what I think. I think that people delivering healthcare will think they're doing social determinants work. Then 10 years down the road, they'll realize they weren't. They were doing social needs work. They were meeting social resource needs. And I think that's great. If from a Maslow's hierarchy, right? Like it's really important that you have food, right?
Right.
But those aren't social determinants. And I always explain it like I was talking to someone who did cardiac care, and he was saying, one of my patients doesn't have plumbing, so we're doing social determinants work because I took into account that he has to lift a bucket to flush his toilet. So I was like trying to come up with other ways that he could do this. And I stopped him and I was like, that's not social determinants. The social determinant there is, why does that guy not have plumbing? Why does this whole neighborhood have poor housing quality? And to expect healthcare to like get into that fight, maybe asking too much at this point, right?
Right.
But I would expect an easy first step for us that we've really focused on is making sure that when healthcare institutions are doing predictive modeling, artificial intelligence, right? They're doing like kind of machine learning to segment risk for their patients so they can meet each patient with what they need. If you do not have environmental data, social and environmental data in that model, good luck. It's incomplete. We know 80% of what determines health happens outside that clinic. You can ask someone every question, son, every screener for social needs, every community health worker. They're amazing. They're part of it. But you don't know what you don't know that's hurting your health. And so what mySidewalk tries to do, right? Fill that gap, get that data that we just talked about, which is like particulate matter. I could ask, what's the particulate matter in your community? You don't know. You know if it looks dirty outside, but you could be fooling yourself and breathing in all these poisons, right? So filling in all those gaps will create better models, more efficient care, and I think lower costs, improve outcomes. And that's what we're trying to do, right? So I'm just being realistic because we also want to disrupt implicit bias with our data stories. Like we're doing that too. We're trying that, but I'm thinking like first things first, inform your models better if you're trying to do this really cool data science work, which a lot of people are. So
totally agree, and it gets me really excited about the possibilities of pulling together the different data, clinical, environmental, everything that we've talked about. Unfortunately, we are out of time. These always seem to run too short. But thank you for joining us today. Really appreciate it. Thank you to our audience for tuning in. You can learn more about the show on the programs page at healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesandVBC. And be sure to follow SPH on Twitter at SPH Analytics. I'm Matt Fusan, bringing you voices in value-based care you should hear. Until next time, thank you, Sarah, for joining us. And everybody have a great week.